Welcome to SACME Virtual Club. It is Friday afternoon. It's raining where I am, and I'm happy that you chose to actually spend the next hour or so with us. Today we're going to talk about the implications of implementation science for us, for medical educators. And I'm delighted to have two well-known faculty members, colleagues joining us to lead this discussion, and they are also the authors of the journal article that we chose for you today. So the Medical Education Online article that was published in April of this year was really authored by David Price and Barbara Barnes and a number of other colleagues. So I do want to mention that as always, we will be recording this session, and if you or any of your colleagues have missed a chance to participate live, you'll be able to join us and view and hear the podcast on SACME website. Also, I do want to mention that it's really important for you all to participate and engage in discussion, because that's what we all value the most, and that's how we learn best. So when we designed this session, it was with that in mind, and I do want to remind you again to do that. The way to do it is to either raise your hand on the left-hand side where you have the column, and we'll see if you've raised your hand, and then we'll unmute you and let you pose your question. Or if you choose to put a question in the text section, you can do that as well. Without further ado, let me introduce our speakers then today. In our faculty, we have Dr. David Price, who is the Senior VP at ABMS Research and Education Foundation. David is also the Executive Director of ABMS's Multi-Specialty MOC Portfolio Program. He is the Professor of Family Medicine at the University of Colorado Denver School of Medicine and the Chair of the AAMC's GEA section on Continuing Education and Improvement. We know David very well, and it is exactly this wealth of perspectives that he brings to us that is always a pleasure to hear something new and learn from. In addition to David, we have Barbara Barnes, dear colleague who really needs no introduction. Barbara comes to us from University of Pittsburgh School of Medicine. Barbara has held many leadership roles in our communities at AAMC, at ACCME Alliance. She was the president of SACME, and she currently holds many leadership roles at the University of Pittsburgh. So with that, I would just turn you over and this program over to David. Thank you.
Well, good afternoon, everybody. I hope those of you on the East Coast are in safe places that are covered and on relatively high ground, looking at the news. I thought what I would do briefly is primarily provide some context. As Mila mentioned, we're not going to do what a traditional journal club would be, which is going through and tearing the paper apart. We really wanted to have folks to have a chance to think about the concepts that we tried to lay out on this paper and how they could be applied in our work as CPD professionals. To that end, we've asked three reactors to talk about the way they have applied some of these principles in their work, and Barbara will introduce our panel of reactors, respondents, and learned colleagues. Contextually, if you think about a spectrum of what we do from the a new term I learned earlier this week, the transactional education process, aimed at attitudes, knowledge, belief, skills, and competencies, followed by efforts of learners to implement what they have learned in order to improve quality and performance, in order to achieve outcomes and climb up those levels of Don Moore's pyramid, if you will. Implementation science provides a set of theories, constructs, frameworks, and tools that inform that process of us going from developing the transactional education to the implementation of what we're trying to do in education quality and performance improvement to achieve those outcomes. What we tried to do in this paper, our cast of a dozen authors, is we conducted a narrative, non-systematic review to highlight several ways implementation science can be used in this process. And we tried to provide that by embedding it within a case, and we tried to get at this by providing examples across the continuum, particularly at the level of the individual, the team, and of the organization. And for those of you who happen to have the paper handy or to look at it, we've tried to lay out some of these things in a relatively easy to look at visual form in tables. So particularly if you have the article with you, tables 1, 2, and 3 talk about some of these tools, constructs, and theories at the level of the individual, the team, and the organization. The other contextual thing I'll mention before turning this over to Barbara is that all of the authors, our colleagues on this paper, are CPD, are educators. Most of our co-authors work in the UME and GME space, but we're all come from a health professions education background. We are not implementation scientists per se, and as we make the case in the paper, it's not necessary for us to become implementation scientists per se, but a familiarity with these tools and constructs can help us pick and choose from the wide variety of things out there in order to help us achieve what we're trying to achieve by our educational intervention. So with that, I'll turn it over to Barbara.
Thank you very much, Van. I'm sorry, David. We really wanted to spend the time today talking about the specific application to continuing professional development. And as David said, this was a very representative group of authors across the continuum, and only a small proportion of us really had a lot of responsibility in continuing professional development. So what we'd like to do today is to have our reactors really talk about some of the things that they have done in their own institutions. And we're going to start out with our dear colleague Van Harrison from the University of Michigan. I think all of you probably know Van. They were one of the early participants in the ABMS portfolio program, and we thought this represented a very good example of how implementation science could be related to continuing professional development at the level of the individual practitioner. Again, I don't think Van needs too much of an introduction. He's a well-recognized researcher and academic in our field, and has really transitioned his own career from primary focus in CPD to looking at implementation science, quality improvement, and Part 4 of maintenance of certification. So Van, I'll turn it over to you to talk a little bit about what you've done at the University of Michigan. And the way we've structured this is ask each speaker to spend about 5 or 7 minutes talking about their own experiences, and then leaving it open to about another 10 minutes of discussion from the people in the audience to either ask questions of the presenter or also to talk about your own particular experiences with these type of activities in your own organization. Van?
Yes, thank you very much, Barbara and David. I appreciate, and Mila as well, I appreciate the opportunity to share a few ideas. It's been interesting for me, since my training is in social and organizational psychology, to very much appreciate the paper that this group of authors put together. It felt like old home week because given my background, I'm trying to think about all of those levels with this specific emphasis on the individual and the organizational settings. In relating what we did in trying to set up a program here, I very much related, and the focus of my comments is going to be on Table 3 and Table 1. A major lesson that I'm trying to communicate that I keep coming back to is that you need to consider multiple levels of a system under complex adaptive systems and theory of diffusion of innovations. To set up, you can't just do the education at the individual level. You have to set up infrastructures that provide the resources and background to have teachers and resources to help have the ongoing sustained activities. For us, the other part to realize is whether you're looking at the group or institutional level, groups are composed of individuals and institutional leadership are individuals. And so the lessons on Table 1, how do you approach individuals at those levels to get something started, is a way to apply the individual level theories to make changes at the group and organizational level. For example, and if you want to jot this down just so you can follow me since I don't have a slide, I'm going to talk briefly about how we worked at the institution level, the department level, the quality improvement project level, project lead level, and the participant level. Because we realized that to develop a program whose ultimate aim was to have individual physicians experience successful engagement and quality improvement, we needed to think of education occurring for people at all of those levels. We started with our institutional leaders and helped them understand the opportunity for this new program, the needs it met for maintaining the certification of our physicians, the cost benefit that it was to the institution, the feasibility and how it could work. And as you look at the individual level theories, several of them apply, particularly the first one on the list, starting with attitudes, beliefs that they had, and information we had to provide to them. We identified 4 key leaders: the head of our medical group, the chief medical officer over the hospitals, the head of our quality improvement training, and the head of our medical education, and met with each of them individually to educate and work with them. A lot of one-on-one education using those individual principles before we brought them together as a leadership group so that they could come and work effectively as a group in overseeing our program. At the department level, we had to meet with every one of the department chairs and explain the options of the program for them and how it would fit. And because different specialties have different requirements for maintenance of certification, we had to customize the message, letting those who would oversaw specialty physicians who would greatly benefit consider how the program might be developed, and those for whom the program offered little, simply an awareness, so as their maintenance of certifications for those specialties evolved, they knew who we were and would be ready. Particularly at the department level, for the departments where it made a difference, we made a major push that they needed associate chairs for quality improvement. We needed in the department level to develop infrastructure, and we educated the department chairs about the benefit for it. It's very interesting to meet with the department chair and say, what is your department's quality improvement program of activities for the next 2 years, and how can you choose 1 or 2 projects to document for MOC, and watch them draw a blank because they have no plan or coordinated arrangement for their quality improvement projects and the need to create that infrastructure. We spent and continue to spend the bulk of our time working with individual project leads. A lot of people leading projects do not have formal training to explain what they're doing, to be able to document it, so that other people can understand how they carried out 2 or more linked cycles of data-guided improvement. And we ended up having to actually create a flipped classroom because we have to present this information so regularly to so many people on just-in-time one-on-one teaching and training. We actually put the basic materials online on our website. We asked the project leaders to review them, and then after they've done the offline or online, not in real time looking, then we hold meetings, often by phone, where we go through and discuss how those concepts, principles, and actions apply to their specific situation. That cut a lot of time out of our interactions and gave them a reference to go back to. Finally, at the participant level, we don't interact directly with the participants that much. We act through the project leads, providing them with materials, frameworks, so they're more effective in working with the participants. Just as many medical education offices train the continuing medical education program lead, and then they're the ones who actually deliver the education. The project leads deliver the training and education about each step, and we hope we've prepared them. So what I hope I've been able to do with that example is help you realize, drawing from this paper, Table 3 provides a broad perspective of the multiple levels at which you need to think and work. But Table 1, for individual learners, helps you think about how you're going to work with people who need to learn at each level, and understanding the audience at each level, what they need to know, and the role they need to perform for the overall system to function. So that's a quick push through those ideas and how we really applied them and continue to every day.
Great. Thank you so much, Van. We would certainly welcome questions from the audience. As Mila said, you can raise your hand and then we will recognize you and you can ask your question. Just to start off, Van, I think it's very interesting that a lot of times, we as CPD professionals really look at the, sort of the implementers as our target audience. You really began to understand the whole change process and initially focused on sort of those change agents that were necessary to affect the change in the end users. Do you want to talk just a minute about how you came to that conclusion?
Yes, and one of the rationales for implementation science being multidisciplinary is a recognition that you need to think about multiple levels and backgrounds, and the realization that we needed the leader support and funding to be able to allow us to then work with the departments and create the oversight there for their quality improvement planning, to work with the actual quality project leaders of the quality projects down to finally get to participants. We realized that we needed to simultaneously consider the needs of multiple audiences and how they interlink, and that when you think of education, rather than just thinking of the final recipient, you have to think of everyone up and down that process. And having a multi-specialty group that we work with and their perspectives helped us realize that we needed to think about all of those folks.
Great. Mila, do we have any other questions?
I actually don't see any hands raised, but yeah, I really appreciate your thoughts, Van, because I think we are at the point when we increasingly recognize that it's not just the learning theories that we face in our space, and it's not just even quality improvement strategies and tools, but increasingly it's about the improvement, the change management, and what comes maybe out of the business school, and those strategies, as well as learning about learning organizations and how teams are formed and that kind of stuff. So thank you very much. Great examples.
Great.
Do we have anybody?
Looks like there's a question from Mariana.
There we go. Jim, can you unmute Mariana?
Okay, Mariana, you should be able to ask your question now.
Okay, let me read this. So Mariana is asking, what were the major barriers at each level as you had conversations with individuals? That's the first question. And then secondly, how did you deal with these barriers? I think that's a man.
Sure. Just briefly, I'll hit a couple. At the institution level, we had to make a business case. Why should they fund and endorse this program? And explain how physician time was being used, how this would save our physicians time where they're working on their own time individually to get credit for what they're doing, and how it would help the institution advance the quality improvement priority initiatives by aligning people. So the business case and what's in it for them. Similarly, at the department level, the fact that departments would benefit greatly by having more systematic planning for their overall QI programs, and then if they had a plan, they could select an activity every year or 2 years for people to get their Part 4 maintenance of certification requirements met, and that rather than this being a haphazard thing, the planning would align the department's activities and the individual interests at a level where they felt it was, they really recognized that it would make life better for them. Project leads were relatively easy in terms of the biggest barrier was their lack of vocabulary and guidance. So that whole educational package to help them, holding out incentives like working on this would help you present and publish and help you advance your career. So we tried to anticipate the different needs and questions and what their problems were and help them work through that.
Great. Any other questions? If not, we can probably go on to the next section, which I am going to introduce, and I'll mention that we will have a chance for overall discussion at the end. I was asked to talk a little bit about the team perspective, and we'll be looking at tables 2 and 3 primarily of the paper for this. Table 2 talks about a number of the competencies that we need to look at as medical educators in terms of the needs of the team. And I think it's interesting to note that these are really looking at many of the ABMS, ACGME competency areas such as communication skills and also professionalism, practice-based improvement, and systems-based practice, which is also reflected in the implementation science models used within organizations in Table 3. Just in reflecting on our experience here at the University of Pittsburgh Medical Center, it was interesting to me to look back in terms of our evolution and looking at the team. I think we started out really looking at some of the tools listed in Table 3 and doing a number of activities that would help team members acquire some of these tools and be effective as members of the team. We've done a number of activities related to preparation for quality improvement among our physicians and staff members. And we've also had a very large effort here in terms of patient-focused care, and again, trained multidisciplinary members of multidisciplinary teams that prepared them to actually participate in those teams, which are very far-ranging, not necessarily using traditional quality improvement tools, but looking at improving the patient experience and the environment of care and so forth. And that's been an ongoing effort for probably the past 7 or 8 years. We also had an activity that I thought was one of the most creative titles that we've ever had, which was called 3 Ps Heretofore Not in a Pod. And this was actually an effort in nursing homes where it was recognized that the nursing home administrator, the medical director, and the director of nursing really had very little interaction with one another and really functioned fairly independently in their roles. And we, through our Aging Institute, were able to convene a team consisting of those 3 individuals from about 8 or 10 nursing homes from the region, both UPMC and non-UPMC homes, and convened in several meetings during the year to talk about individual problems in their homes as well as issues that ran across the nursing home environment, and asked each team to conduct a project in their own institution and then report out. This effort went on for about 3 years and really, I think, addressed a number of the competencies related to Table 2, including particularly interdisciplinary communication, and I think also role clarity, that prior to this activity there was really very little understanding of the mutual roles that each individual conducted. And also really developing a shared and team goal, which has become more and more important given the nursing home regulatory environment. However, that effort really was not sustained, partially because it was voluntary on the part of the nursing homes. I think some of them have maintained it, but it was really not. It was really sort of a special project and not under a single institutional umbrella. Our latest effort, which is I think the next natural evolution, is really to look at how we can infuse CPD into the team-based practice, the actual clinical practice. We at UPMC are part of the National Coordinating Center for Interprofessional Practice and have spent some time looking at what we consider our model interprofessional practices across our health system, and have identified about 20 practices that we think are such models. And these include both outpatient primary care and specialty clinics, and some of which are hospital-based and some of which are community-based. Some are, as I mentioned, primary care. We also have specialty clinics such as our trauma clinic and our craniofacial clinic at our children's hospital. And in this effort, we are in the process of assessing the existing competencies in those team-based practices, and then implementing actual practice-based continuing professional development and quality improvement within those practices based on those individual competency gaps that we have identified. We're really excited about this effort. We think that this is really where we want to go in CPD in our institution as much as we can, to really get down to the people who are working together and identifying their own needs and understanding how we can address those needs with CPD. And David or Mila, I don't know if you have any thoughts or comments while we're waiting for other folks to have any questions about what we're doing here in Pittsburgh.
I don't see anybody raising their hand, so I would like to invite you all to not be shy. Raise your hand or put your comments in the chat section, and I'm sure everybody's doing a lot of great stuff along these lines. And I know that some of you would not be too shy to share, so please do contribute. And while you're thinking about it, Barbara, I think this is really exciting time for us because we all have, and I can't wait to hear more about the fusion part of this later on. But speaking of teams, I'm just curious about, in the era of competency-based education and transferring that into the practice, the individual competencies versus these functioning teams and what is required in translation. And I'm particularly drawn to the work of researchers like Lorelei Lingard and others who talk about the difference and the fact that you could have highly competent individuals and highly incompetent as part of incompetent and not functional teams and other dynamics there. So anything you want to share about those particular experiences?
Absolutely, and I think you're exactly right, and I think that's one of the issues that we have with team-based care, that a group of individually competent people do not make a competent team and do not necessarily deliver the highest quality of care. One of the resources that we're really drawing on are the IPEC interprofessional competencies that are not necessarily validated, but I think a very good framework to draw from, and that's really the kind of the backbone that we are using in this effort as we move forward, and really trying to identify metrics that we can use to identify progress in these competencies, and drawing on some of our existing quality measures, including patient satisfaction and so forth, to really understand the progress that we're making from the patient's point of view. I mean, really, that really is, I think, one of the best metrics of team-based care, when you can get feedback from your patients and say, yes, this was a terrific experience. That means that the team has really worked together.
That's right. Great. Well, thank you. Any hands? I'm not seeing any.
Well, then we could just move on. We've asked Janine Shapiro, our great colleague from the University of Rochester, who's also been a very active participant in SACME, to really talk about the application of implementation science at the organizational level. She's had the opportunity to participate in the AAMC's AE4Q and PE4Q efforts, and has been very engaged in that regard. And I also see that Nancy Davis is on the call, and we really appreciate some of your comments, Nancy, after Janine tells us about her experience. Janine?
Yeah, great. Thank you. Good afternoon, everyone. It's really my pleasure to be joining. And happy to know that Nancy is here, because Nancy did come to visit us for the Teaching for Quality initiative. So even though my remarks are aiming at the organization level, it really has had a big impact at the individual and team levels as well. So I'd like to comment on that as well. So last October, we brought to our place, the University of Rochester School of Medicine and Dentistry, the AAMC A4Q and T4Q. We planned that, and I think that was the first time that it was the two initiatives were combined into a single visit. So we started with the Aligning and Educating for Quality, and had the 1.5-day course, Teaching for Quality initiative, really during that time frame. So it was over a course of 3 days. So first, in terms of organization, so it did take a bit of preliminary work to engage the leadership from various constituency and key stakeholders. My work is in the Office for Faculty Development and Continuing Medical Education, but engage the leaders in quality improvement and patient safety in the conversation, and then extend it with other key stakeholders. And I think that was very good because it helped change the conversation and underscore the need to, as the title say, align education with quality. The course, the Teaching for Quality course, which Nancy was one of the leaders for that course, was very successful. We had a full house, 30 participants. What was very interesting to us is that this first round was faculty from the School of Medicine, and a lot of the educational projects were in GME. And it was very interesting because relatively close to that time frame, we had the Clinical Learning Environment Review, the CLARE visit by the ACGME, which underscored the need to really improve the education we provide in quality improvement and patient safety for our residents. So we were all talking the same language, really, about the need to change the conversation here. So this was a collaborative effort with quality improvement, CME, faculty development, and GME leadership. As I mentioned, a lot of the projects were in GME, but we also had some projects at the faculty level, educational project in quality improvement and patient safety, and also medical student education. When we relate this to implementation science, and which was really well outlined in the article that we reviewed for this journal club, I think it meets a lot of the goals. For example, if we look at what implementation science is all about, which is translating and implementing new knowledge and skills in the work setting, the rationale for the Teaching for Quality initiative is exactly that. We need faculty development so that we can model and teach quality improvement and patient safety, and give the tools to our educator on how to use educational strategy and implementation science approaches specifically for practice-based learning and improvement and quality improvement and patient safety. And we have found that it's a big impact on the individual learner, the faculty, impact on the continuum of education, and impact on teamwork, and I'll come back to that. We were, as I mentioned, the impact on the organization and the contacts, but also impact on team-based care, and this is something that was emphasized in the article. So when we look at what we did last October, this was for us the foundation, because now we're taking it to the next level of planning something that is adapted to our local need. So now we are implementing an ongoing course, which will be a 2-day course, as well as having educational project in quality improvement and patient safety. And the course, we're adding specific content in quality improvement and patient safety so that our educator have that content expertise, or at least knowledge and skills. We found that in order to be, for the faculty to be able to teach it, they need to know it themselves. So we are adding that content, which was a prerequisite last year, but we find that we need to have it part of the course here, as many of our faculty really lack that knowledge in order to teach it. We will be emphasizing implementation science, theoretical model, and practice, which were very nicely outlined in the article, emphasizing as part of our ongoing curriculum team-based competencies and knowledge of team development. Again, an important component of implementation science. So we're expanding the offering now to include not only faculty from the School of Medicine and Dentistry, but also faculty from the School of Nursing and faculty at our dental school. Enhancing a little bit of the interprofessional work, and future rendition of the school will actually, a sign-up will be for team-based team to join as a team, as an interprofessional team. So we may have pharmacy, social work, and so on to join as a team. So there are many different models how we can use the foundation of teaching for quality to adapt to specific needs at the organizational level. So we're really looking forward to the continuing implementation of teaching for quality here. Another aspect that was the end result of our visit last October is to bridge our CME Faculty Development Committee with Quality Improvement Committee. Rather than having separate committees, we'll have one specifically, a new steering committee of aligning and educating for quality, so modeled again after the AANC program, with a focus on what can we do beyond the teaching for quality course in educating for quality. So that's how we have applied the Aligning and Educating for Quality and Teaching for Quality initiative from the AAMC for ongoing work in quality improvement, patient safety, the development of our faculty in that regards along the continuum of education, and changing the conversation at the organizational level. And happy to answer questions.
Great. Mila, I see that we have a couple questions and comments.
Hi, Barbara. It's Nancy Davis.
Hi, Nancy.
Hi, great. You can hear me. So first of all, thanks, Janine, for that great synopsis of what you all did with AE4Q and TE4Q. I think you were kind of the poster children for aligning both of those programs. But I just want to say a couple of words about the article, too, and thanks to Dave and Barbara and all the authors who did such a great job with this very pragmatic article. I think it's very important. We have started doing a Quality Improvement Journal Club here, and this is in the queue for discussion there, because we run our journal clubs in the same way as Dave mentioned, where we don't critique the methodology so much as just have a discussion and synthesis of some good work. So I'm definitely planning to use this for that. And it's a part of a bigger program that we're embarking on. As Janine said, a lot of the teaching for quality has been geared toward GME faculty because there's such an important need now with the new ACGME requirements and the CLEAR visits. It's really raised awareness of the need for teaching quality improvement and patient safety in our residency programs. And even if you're not directly involved in GME, that faculty development component is real. So we find we're actually teaching the faculty along with the residents because they haven't had this kind of education either. So I think very pragmatic tools, like you all have suggested in the article, are really helpful. And then the last comment I'll make is just around alignment and the fact that all of this needs to be integrated. So for example, as a part of OPPE in hospitals, that tends to be very siloed in the medical affairs office, where really the OPPE needs to be used as needs assessment for ongoing professional development. So I think there's a lot of integration that still needs to happen, and activities like this are really helpful to get those of us really engaged in CPD thinking more broadly and getting involved where all of this education needs to be. So I'll stop there.
Great, thanks, Nancy. And Janine, did you have some other additional comments?
Yeah, and I think, you know, part of the emphasis of teaching for quality is dissemination, and along those lines, another initiative we are implementing is a quality day at our institution, where we will be able to spread the educational project and disseminate the educational project. So emphasizing scholarship is important. The other thing that I wanted to add is that talking about the organizational context, it is an opportunity, and it's a win-win for our quality improvement office and patient safety to push out educational initiative as well. So we are not just leaving it to the individual to design their own project or think about an educational project in quality improvement and patient safety, but it's an opportunity for the institution who's trying to change something, for example, handoff education and impact on quality of care, rolling those out as educational project that people can participate. So trying to give, in addition to certificates that we have found that encourage involvement, is we have providing CME for it, but also we have malpractice reduction premium credit here. So we find that teaching for quality is an opportunity to improve quality of care, therefore reduce malpractice problems. So we are giving incentives for that. So there are different ways we can incentivize and find a way to engage and motivate our faculty in participating.
Great.
Thank you, Janine. So I have a question. You started talking about the spread, and I know that many of us are doing great quality improvement projects, and I do want to say that the two big sort of initiatives in our space, both joint accreditation that is supporting this need for team-based practice with education, enabling that with accreditation systems, as well as the MOC portfolio program from the ABMS that David is spearheading, are really two wonderful drivers for us in this space to become players and be really involved where it matters in our organizations. With that in mind, as I said, we all do projects that are at times really good. We tie them to measures. Some of them are global measures, Hospital Compare and others. And our experience has been that we've achieved great results, but then, you know, and they stick for 6 months, a year, even 2 years, but then as soon as you sort of take your eyeballs off of it, as our colleagues say, and you know, apply attention somewhere else in the organization where it's needed, oftentimes you see those great results slip again. So this is a question really for everybody. What have you done in your organizations from your perspective or part of a larger team that has contributed to that sustained change in improving whatever measure?
Van, do you have any thoughts about that?
Great.
Can someone unmute Van, please?
Can you?
There you go.
Okay.
Yes. Actually, I've got two thoughts. The first one is a broad sort of conceptual one. Using an analogy, you have to think about how often all the individuals in the organization are going to change, but the organization is still going to function. The analogy is about every 7 years, most of the cells in the body turn over, but you're still an individual. When we look at thinking at the across time, if you embed the knowledge in a set of individuals without building it into the infrastructure, over a period of 20 to 25 years, there's no one in the organization, or virtually no one, who was there when that was set up. So how do you embed it into systems, standard work descriptions, standard review and check mechanisms? This is when you go beyond the individual to setting up the infrastructure across the team and the organization, across critical activities, so that the roles and explanations exist separately from the individuals and can be picked up on. It's a real challenge. I guess the anecdote that I have in quality improvement, the example we use, is a group did the first cycle and found out that everyone who had participated in the planning was doing fine, but they'd forgot residents and fellows were rotating through, and no one remembered that they needed to be trained and taught. And so this second and third level of how are you going to sustain in an evolving organization, just as Mila pointed out, as attention shifts, how do you sustain what you've got and take that into your planning? So that's some pretty direct thoughts about this as a more fundamental problem than most of us want to try and tackle, but we need to.
Thank you, Van.
And Janine, I was interested in your comments about the clear visits and so forth. Do you think, having those, accreditation and sometimes regulatory drivers are another way to sustain some of these efforts?
Absolutely. So our Senior Associate Dean for Graduate Medical Education is one of our course director now for this our local Educating for Quality course and program. First, I think just showing the ACGME what we're doing will be extremely important. I think it's really a significant initiative to improve the education in quality improvement and patient safety. Coming back to the last question that Mila asked, it's ongoing work. Faculty join, resident join and leave, and so on. So it never ends. So it has to be sustainable. So I mean, we are learning, and we'll have to. I could see where it's going to evolve over time, but already when we'll be having the course in early November, and of those who are signed up, again, a lot of our residency program director, they're involved with GME, so it will be ongoing work. But I think at some point when we continue the conversation on CLARE, having a systematic approach, our next goal is to identify one person in each clinical department who will have that responsibility of educating the resident quality improvement and patient safety who will have gone through this program.
Great. I think Stuart Gilman has a question.
That's right.
Yeah, thanks. Hi, everybody. What a wonderful discussion, and my thanks to those of you who created the manuscript and to everybody discussing. I was going to throw out an observation that might start an argument, but it might be fun if it does, or we'll see. But I've come to be, I think that as we advance with implementation science, which is building on a lot of quality improvement implementation issues, we run into a lot of challenges. Are things we're doing as we try to learn as we go in a systematic way, are the things we're doing research or not research? If it's research, are we exempt from human subject oversight or not exempt? And then when it comes to the actual scholarly products, I actually am coming to think that the additional scholarly publication in a way systematically strips much of the information necessary to advance implementation and dissemination. That is, the fundamental issue of what's research versus improvement is research is to get to the generalizable. Nobody can implement the general. We have to implement the specific in our context, right? And we've heard about context earlier. So I guess my concern is that to the extent that we address local context of programs and institutions and systems as limitations of a study, rather than really be explicit about what it was, what the conditions were that under which an innovation occurred, we can retard our ability to really communicate work and advance diffusion.
Really good
Stuart,
point.
This is David Price, and Stuart won't be surprised that I totally agree with everything he said. A lot of the narrative that I've seen now in the quality arena is to talk about this issue of efficacy research, i.e. the randomized controlled trial that's so controlled nobody can apply it, versus effectiveness research. And one of the reasons I am such a huge mixed methods research kind of guy is because the typical data can tell you things if it worked in a given setting, but the whole narrative piece, you know, some of the barriers, relating back to the barriers question, the reflective questions that a lot of us build into our CPD activities, including those in these improvement efforts to find out why something worked or why something didn't work, is so important for folks to be able to look at, in addition to the context, which quality efforts now are increasingly being asked to show when they publish, so people can say, this context is sort of like mine, this context isn't sort of like mine, and here are some of the things that worked in this context, and here it didn't. The second thing, in my Kaiser career, when I started learning quality improvement, I read a book called Edgeware by Zimmerman and Plisek. Paul Plisek is one of the complex adaptive systems guys. And the crib notes version of Edgeware is that there are a few things in any given initiative that are so key that if you mess with those, it's not going to work. But everything else is sort of, I won't say optional as much as those are things that you should look at your own system in and adapt. So this gets to the idea of adaptation versus adoption. Edgeware is a really great book. It's an hour, 2-hour airplane read ride. And I own no stock in the book, but it's something I refer to often. And if you think about some of the ways of applying things, particularly in complex adaptive systems, which I've heard us talk a lot about on this call today, that's a great little primer.
Thank you, David.
Those are great observations, and really have relevance for SACME also in terms of our research committee and what kinds of dissemination we support and embrace and foster.
Absolutely, absolutely. We do have a couple of minutes, and I would like to invite you to maybe contribute if you still are interested. Any more questions or comments or any kind of addition?
Yes, this is Janine. Can you hear me?
Yes, we hear you.
Yeah. So I just want to add one more point in terms of the practicality and the implementation. One thing I really liked about the article that we have this afternoon is blending the theory with the practice, and I think it's so important to understand the theory to inform the practice. For example, one of the theoretical model that was mentioned is planned behavior and reasoned action, right? So intent to change, behavior precede actual change. Many times the leadership may not understand that people have preconceived beliefs, attitude, they're not motivated to change, But yet many policies are just rolled out without that sensitivity and that understanding that people need to understand why they have to change. So in terms of the dissemination and the practicality of disseminating, it's important to understand the theory, and that informs the practice. So, and I think, as one more comment I have, it's a great opportunity for the CME leaders to be part of that change, and even at time educating our leadership on implementation science strategy, team-based competencies, etc. So theory informing practice, I believe, is very important in enabling that dissemination and understanding what is needed.
Thank you, Janine. If we don't have any more questions or comments, I would like to invite David and Barbara to maybe give us their final words.
All right, David, I'll defer to you.
I just want to thank everybody for their questions, and thank Barbara and Van and Janine for sharing their perspectives. I hope the format of this was helpful. Again, the paper is available through the link for the Journal Club. It's also open access online. The question about IRBs we didn't exactly get to. It's a very interesting discussion, and that's something we may want to tee up at another time. But I think the last thought I'll leave you with is you guys are all doing wonderful sorts of work that, whether it's research or quality improvement or some combination of the above, it's very valuable and generalizable knowledge. So I hope that through SACME and through the academic efforts that SACME is undertaking, through the AAMC, for those of you who are participating in the portfolio program, or just through your own CPD shops, that you write this stuff up and get it out there. It's a wonderful opportunity for us to learn from each other, and more importantly for us to share the things that are working and even the stuff that's not working, so we can all take better care of our patients and we can play a role in that as CPD individuals. So thanks very much, and I appreciate being asked to be part of this group that used our paper as a discussion point.
Thanks, David. Barbara?
Yes, I would, again, just like to thank everyone, and I think we got a lot of interesting feedback today and a lot of food for thought, and I hope that we could incorporate some of these issues into future SACME meetings and perhaps some of the journal clubs.
Well, thank you very much. With that, I'd like to thank you all for taking your time to be with us and to participate. Again, to all of our faculty, Van and Janine and David and Barbara, thank you again for sharing your thoughts with us, for the wonderful article, and encourage you all to participate, to remember that this lives on the SACME website, so if you've missed something, you want to go back to one of the sessions, please do. So we do have a chat session. You can continue to engage with others, with faculty, and with colleagues on a particular topic using that opportunity as well. So you will get an evaluation question. I ask you to please do fill out those. That tells us how we're doing, what else we can do better. And I do invite all of you to let me know topics you're interested in, or submit an idea, an article, and volunteer to present within our SACME Journal Club. With that, I wish you all well, and thank you all for participating.